Good afternoon. In order to stay on schedule, we're just going to unfortunately have to hold back on the discussion among the panelists and move directly to questions from the field, from the floor. So is somebody there with the microphones? Okay, if you could put up your, can we put up the lights in the audience, please? So I can see. Okay, so if people want to ask a question, could you please ask a question? Ends with a question mark. And if you know to which panelist you want to ask your question, that's fine. Otherwise, we'll choose among ourselves who we think is the best to answer the question. All right, so hands up, anybody who wants to ask a question, please, so the microphones can find you. There's somebody over there.
Yeah, my question is for Dr. Chahandras from Thailand, and I apologize if I massacred your name. You did a very nice job of presenting the public health system in Thailand, but Thailand's also very well known for its medical tourism, Bamrungat Hospital and so on. And I'm curious how that intersects with the public health system, this very efficient, customer-friendly, highly desirable medical tourism facility with the public health system. Does it subsidize it, and in what respects does it pose a challenge that you offer that type of service to people that can pay for it relative to the general public health?
Question. We are struggling. The so-called medical tourism is very much driven by what you could call market force, rather than explicit government promotion. On the other hand, the government would like to see us promoting medical tourism because it has been seen as one of the so-called potential source of income. But in country, reaction or question has been quite strong as well from the health professional as well as the civil servants, whether the government should be promoting too much of the so-called medical tourism. Right now, what the government is trying to do is that they will be promoting what you would call preventive promotive, herbal medicine, spa, and things like that, rather than curative services. But as I say, curative services in terms of globalization, medical tourism is very much a market force. We did some analysis as to how much the impact could be. But frankly speaking, figure doesn't say much about rather than reality. So in conclusion, the medical tourism is affecting the so-called health services for the Thai. But we believe that if the so-called UHC protection is well in place and the so-called motivational factors within the UHC healthcare delivery system is properly designed, we could strike a balance between the medical tourism and the so-called UHC protection. There were some proposals about taxing the medical tourism so that it could be, the government could use the tax to cross-subsidize the so-called UHC, but that has not been properly synthesized or analyzed yet. I'll stop there, but yeah, it's a struggle, but we are struggling with some, balance and interaction between use of knowledge and political pressure. Thank you.
Okay. Please, hands up for people that have questions. In the back there.
Good morning. I have a question for Japan. Can you please elaborate on the metabolic tax that you have in your country and how that affects the health system there?
Sorry, could you ask your metabolic what?
There's something called a metabolic tax or a metabolic tax, if I'm not wrong, in Japan, which like all the people in Japan have to undergo certain tests, and if they're not fit, then they have to pay the tax money.
No, we don't have such tax.
A metabolic tax system.
No. The government try to persuade people to take health checks and to promote healthy activities, but they are not, so there's no sanctions on that. There's some kind of a misunderstanding.
Okay. Mazia, Could you speak a little bit about the Iranian rural health system? I know now Iran has changed from being 70-30 rural-urban to 30-70, but you do have a well-known rural health system, and obviously rural health is an important consideration here in India.
For the point, right after revolution in Iran in 1978, around 2/3 of population were living in the rural area. During the previous decades, a transition has been happened, and now less than 1/3 of the population live in the rural area. So at that time, and right after the primary health care conference in Alma-Ata, a big change happened in the structure of the health system in rural area. They initiated a specific, started a specific structure which is called health house with a specific catchment area, and they use the community health worker, which is health behbars, with a minimal education in health to provide some services, especially for primary health care and maternal and neonatal children and infectious disease at that time. This helped a lot to provide necessary health services to the rural area and changed a lot in health indicators in the rural area. But after epidemiologic transition from non-communicable and maternal and neonatal conditions to non-communicable disease, the system hasn't changed properly accordingly. So at the moment, we have the same problems with non-communicable disease in the rural area. The behbars and community health workers are not completely ready to address non-communicable disease and risk factors. But the system is working to train them to address this problem.
Okay, questions? This gentleman up here.
Medical oncologist. I have a question for a colleague from Cuba. So Cuba has been a dark horse in terms of healthcare players. What are the lessons which Cuba would like to teach the rest of the world? If you were the WHO chief, what would you do to make this a healthy and a happier place to be? And Cuba really exemplifies that currently. Dr. Osvaldo Gonzalez?
So, sorry. If you speak slowly, maybe I understand.
¿Cuáles son las características del sistema en Cuba que usted piensa sería muy importante para el resto del mundo?
The health system in Cuba is the distribute is the organized the primary level, second level is the hospital, and first level the research institute. But it's this one is the object is objective for level, but it's the primary attention is the first levels is resolve 80% the problem health, but it's a assistant sanitary with the doctor and nurses the family. We are organized in health area. The second level is the resolves 15% because the hospital is a treatment and prophylax the complication and the three level is the treatment, the sequelae, and rehabilitation. Maybe is the organize, the structure is very important, is the outcomes.
I think one could add to that the massive education process for medical workers that Cuba has, which is also key to its success and also to its balance of payments, but also very important if you're not struggling to find doctors to provide all this primary care. Next question.
My question is to Japan. You did mention that as far as your funding is concerned, about 48% is coming from premium, 38% from tax subsidy, and about 12% from user charges. What I wanted to understand, when you pay, say, from tax subsidy, are you paying across the spectrum to everybody, or are you directing it to certain section of population? Just to make my point clear, suppose 100 people have to be paid this, are you paying to all 134% or 38%, or you are targeting it to certain section of population? If you are targeting, how the target population is decided?
It's a bit complex issue. So people need to pay 30% at the point of subsidies, usually, in general. So it's so if you look at the statistics of health expenditure, and with the households pay 30% of that at the point of subsidies as user charges. This is explained by the additional coverage by catastrophic insurance. So if you pay more than $1,000 in US dollars, you need to pay only 1% of user charge. This is, so you can understand? And the premiums things are different. So we actually have more than 3,000 insurers. Each are responsible for make ends meet, but it's practically it's impossible. So the government has been developing the cross subsidy.
Karim, could you talk a bit about the regulation of hospitals in public hospitals in France? Because I think it's a very important area that we haven't really talked about, is how they handle quality and productivity and efficiency and the source of fund with the government using its funding as a way of a bit of a stick and carrot.
It's a broad question, but then as in every country, the number of beds is regulated, so we try to make a correspondence between the size of the population, the need and the opening of the beds in public hospital. I think the question you want me to answer is about the payment for performance, how we pay the hospital. So we pay the hospital mainly on a kind of DRG system. And the thing we're doing, as I was saying, like we try to control health expenditure from the social health insurance. Some public hospitals are paid mainly by the social health insurance, even if there is a co-insurance. And what happened is like the tariff for each DRG are set up at the beginning of the year, and the overall budget for public hospital is set up at the beginning of the year. And then we follow the expenditure, and if during the year the budget start to rise a bit higher than expected, then we can revise the budget. It's a way to control the efficiency of the system and how you produce for a given amount of money. Answering your question, or do you want more to know more?
Okay. I think there's also, it's pretty hard for a public hospital that's not working efficiently to get additional funds for building and things like this as well. Is that not true as well?
The thing is, this is the system, but it's also theoretical, because if you've got like a public hospital that is working only on children, for instance, in Paris, and if they overspend during the year, we are not going to let them say, okay, you can close for 2 months and don't take care of the children. So it's also kind of like pressure, but it's not a tight and so strict control hospital by hospital. It's more general.
Okay. Next question, anybody from the audience? Okay, somebody here, okay.
Okay. My question is directed to the dignitary from Brazil. In your presentation, you said that majority of your people stay in urban areas, while it's the reverse in India. Is there a difference in the behavioral patterns of the patients who come from urban areas and rural areas? And what are your cancer care facilities in the rural areas?
I would say that in the Brazilian experience, it is quite different. One major success of the Brazilian health system, I didn't have the time to talk about it, but it is in the slides, is a family health program that was based on the Cuban experience and was very successful in Brazil. Basically, the idea is that every family is covered by a family health team. And most of the activities of the family health team is to go to the population, to the households, to identify risks, map health status, and send patients to health facilities when needed. Okay? It was very successful. The program expanded in a few years to cover 100 million people, and the impact on health status was also very significant. However, this same program has found it very difficult to take root in large urban areas, because it is mostly an almost community-based program. So it was very successful in areas in which were not covered previously, and to bring this population, which is mostly poor, to have access to health services. In large urban areas, this is where most facilities are. So they already had access, and they already had a usual behavior of seeking care at hospitals' emergency room. So I think this illustrates very well the fact that the reality is different, health-seeking behavior is different, and very likely the programs or initiatives to strengthen primary care should be different in rural areas or small urban areas and metropolitan areas.
All right, another question?
Thanks. So I'm Dr. Amir Sheikh. The question I had was, the theme for the conference is healthcare, a commodity versus a basic human need. And I'm reminded of a pharmacoeconomist who said healthcare is an economic good with a finite supply, but a basic human right with an infinite demand. So the question for the panel is, do you think it's time, against the backdrop of the universal health coverage, are we being too ambitious when we say all people should have access without financial hardship? Or can we reimagine healthcare as basic healthcare services and products as a fundamental right, coupled with the higher end products and services which might be considered as a commodity? It would be nice to have your reflections on that.
Okay, I'd like to start that one actually with Bernard, because the Brazilian Constitution quite clearly states that healthcare is a human right and provision of healthcare is an obligation of the government. So maybe you could talk about how that is being operationalized, shall we say, in the Brazilian context.
I would start by saying that this is a tricky question, which doesn't have easy responses. In the case of Brazil, as you mentioned, the 1998 Constitution says explicitly that health is a right of the people and a duty of the state. That is very nice, but how do we implement this? In fact, in Brazil, what is happening is this concept of right and duty of the state works in the public sector. In the private sector, it is purely a commodity. So this points to two things. First, we need to have, in any country, we need to have integration and collaboration between the public and private sector. This is a key point. And second, I don't think we should think of health or healthcare as a right or a commodity. Healthcare is very diverse. We have many health interventions that are typically population-based interventions. We want the whole population to have access, because if some people do not have access to these services, the whole population will be penalized, will suffer the consequences. Okay? These services ought to be clearly a right and a duty of the state, yes, not to provide it, but to ensure that the population is covered. On the other hand, many health services are in fact a commodity. For example, plastic surgery. I want to have a nicer nose or ear. Why should it be covered? So I think we shouldn't, in this discussion, we shouldn't talk about health in general, healthcare in general, but we should have clarity that some health services, yes, should be provided. We should ensure that the whole population has access to it. Others may be left to each individual to seek for himself or herself.
He's been very patient.
My name is Ajay Kumar. I just want to say any good healthcare is vision, operational efficiency, and finances. We have people from different continents, and we know the cost of care in Europe, cost of care in Latin America, but India is today the cheapest healthcare provider in the world. With doing a CAT scan for $50, $100 MRIs, whole cancer treatment for few $1,000s. So what is the reason we are able to deliver this kind of high quality care in private sector while public institutions are not able to provide in abroad? Is it because of the high cost which has been set already? Or is it because of lack of efficiency? We all know the per capita income, GDP and all. But is there something beyond that? While in India we have been able to achieve, why not in other countries? Even Africa, where we work, is 3.5 times more expensive than India. I would like the panel.
We're not supposed to be Indian healthcare specialists, is my out on that one. You have another group, the next panel, which we really have to move on to now, which will talk about interventions in, excuse me.
One last question, please.
Where are you?
Right here.
Okay. I always let another woman speak.
Thanks. So my question is to all the panelists, and it's got something to do with the wastage that our representative from Brazil spoke about, that there's 35% wastage in the healthcare system. Now, when we're talking about universal health coverage, that's something that the government would definitely want to reduce wastage. And what are the ways in which a government can gauge what is really wastage and reduce that wastage so that it becomes more attractive for a government to implement universal health coverage?
Karine, you want to address that?
I think it's a difficult question, but what we want to keep in mind is like, just to come back to the last question also, is like, if we can't cover everything, then we're going to decide at what time what is a human basic need that the government can afford and what is going to be a commodity. It doesn't mean that it won't change across the time. Like for today, we would say that the French would consider that they can't access to some care that are commodity, that would be considered as commodity like glasses and dental care because it won't be covered by the system. But we reach this point, but it just depends where you start from. And to answer your question, I guess that what you want to cover is something that is efficient. So you should consider it when defining your benefit package. If you can't cover everything, and if your government saying, okay, this is going to be covered by my system, so I'm going to consider that maybe it's not a need, but this is something that I should give to my population because there is a high medical value and because there is a very public health interest in doing that. Then you're going to do it for something that you're going to assess. It's the reason why in most countries we're doing health technology assessment, and it's not only on good and device, but it's also on the type of care that is delivered. Then you take the right decision. If it's not efficient, you're not going to publicly cover it, so it's not going to be included in the package.
Okay, I'm going to leave the last note to Salim, if you want to join us up here. He runs, Salim Reza runs a NGO in Bangladesh, which is in Khulna, which is actually fairly close to the Indian border, and he's working on rural cancer, where you don't have the money to afford to have any waste. So it certainly plays into both the waste issue and the finding low-cost solutions to healthcare problems in India or Bangladesh, Nepal. Salim?
Yeah, thank you, Denise. I want to respond as a neighboring country. I can respond for India because you know why you have been able to do this, to make it successful, Indian healthcare system. To us in Bangladesh, it is a success model. And because the India we know is much bigger than Bangladesh, but you have created the environment and you have created the environment to invest in healthcare, both in public sector and private sector. And so far we understand because of absence of the quality medical care in my country, so people are coming to you. And many of you have that experience and we know that how good your service is. So my response is that it is because of your commitment. It is nothing else. It is because it's a poor country or the underdeveloped country or the developing country, the most important is the commitment. So you have that commitment, and some of my country's people reacted that the Indian doctors and the Indian hospitals are caring us because they have taken this service as a ritual thing. So that is also another added advantage and value in your healthcare system.
I have to give up now. We've already gone over time, and there is another panel to come on. So thank you very much. And the members of the panel here, many of them will be staying on for the rest of the conference, so you can take them aside and ask them all sorts of questions during the conference. Thank you very much. Bye-bye.